Stewart's professor in psychiatry at the University of Tennessee Health Science Center in Memphis, where we got to know her and meet her and work with her. Since that time, we were working in the trenches long before she became the new president of the American Psychiatric Association. And she's going to shake things up. So Dr. Stewart is going to talk to us about adverse childhood experiences. Again, in the perspective of, within the context of working with vulnerable populations. Dr. Stewart.
Thank you, Dr. Juarez. Good afternoon, everyone. I don't know if my slides are here. Oh. Should be right after? Yes. Okay, let's do it this way.
This should be the next one.
There we go. Okay. Yes. Oh, the beautiful picture of the thingy. That's the wrong date.
Yeah, make it okay.
Okay, it's the right slides on the wrong background. Sorry about that. As Dr. Juarez said, I'm gonna go through the quick and dirty version of ACEs and long-term impact on health consequences. This is actually now my soon to become area of expertise of necessity, actually, because of the work that I do in the juvenile justice system and working with kids between 11 and 17 who we missed when they were young, and we might have done some things differently which helped them to get directed into the justice system instead of a long and productive, healthy life. Does everyone, I know you had some discussion this morning before I got here about ACEs. Everyone's familiar with the ACEs study, the original work, and primarily a white, middle class, employed, insured population, and lo and behold, they had these health challenges that no one could figure out, and when they began to drill down deeper, they discovered this whole history in these individuals of these issues. And the original work by Folletti and Anda through Kaiser Permanente and the CDC really helped to concretize what some people, including Dr. Juarez, have been thinking for a long time, that there are connections between what happens to us and how we end up health-wise. And so just as a kind of refresher, I just want to go over the basics of ACEs as a starting point. And I think by the time I'm done, I hope that we'll be able to have some conversation during the Q&A about how this all might fit into any changes to a medical school curriculum. Adverse childhood experiences in the original work, what the researchers did was look at 3 specific domains. As you can see here, abuse, neglect, and what they called household dysfunction in the original that we now really like to think of as challenges. Dysfunction has such a negative connotation. I'm a psychiatrist, so words matter, really matter in my work. So while the slide says dysfunction, I really think of them as challenges that kids are faced with in their early years that leave an impact, an imprint, if you will, on them. And the abuse can take the form of physical, emotional, or social abuse. I was in a meeting yesterday presenting, and the moderator has 2 young daughters, and he was asking me about social media and the impact of social media on especially young kids who are getting involved earlier and earlier, and should he be worried about some of the stuff? And I said, absolutely, because I was raised as I look around the room, probably a lot of you were raised on sticks and stones, may break my bones, but words will never hurt me. Well, now we know for sure that words do real damage. And so whether it's the emotional abuse of you're not worth anything, you remind me of your daddy, and I hated him, and I hate you, and all that whole litany of you're no good, no one will ever love you, you don't matter to anyone, those emotional scars, the physical abuse, the shoe across the room to the beatings until you're bloody and almost dead. And then, of course, the sexual abuse that runs the gamut these days. The second domain of neglect is one that many in the medical profession get into by default because we are mandated reporters, and so when you recognize evidence of neglect or abuse for that matter, and are required to report it, sometimes we don't pick up the next step in that process. It's one thing to recognize and report, it's another thing to do something about it. And I think ACEs gives us a chance, or the work around ACEs gives us a chance to figure out what's that next thing we should do as healthcare providers. And then the household challenges part is a little trickier for some people because there are probably people in the room who grew up in a home where there was divorce, where perhaps someone had a mental illness or even a substance abuse problem, or there was a relative who's incarcerated. And so you think, well, you know, that happens and you get over it and it's okay. I survived and look at me. But when you think about this, most of these things don't happen in isolation. A child who's exposed to some kind of abuse and neglect is very likely in a household where some of this stuff is happening. And the issue with ACEs is the cumulative effect of these things over a period of time. Unrelenting is one of the words that we use to describe it. Regular, unrelenting, continuous, and increasingly more severe in some cases, and without the support of a caring, consistent adult presence to tell you, no matter what is going on, I love you. No matter what is going on, it'll be okay. I will be here with you. And there's a slide coming up that kind of describes that a little better. But these are the things that we are looking at basically in ACEs. So just kind of keep this slide in mind as we move along. This slide documents the way we view ACEs is ACEs has two pathways basically. You can have all of those things in the first slide happen to you, and as a result of someone being there to anchor you, to support you, to remind you of your inherent internal good worth, you can come through not unscathed, but resilient. Or you can follow the other path that says, I am unable to have that support. The stress is now at the level of toxic, and so I am now, by my biology, I'm now bound to a course and an outcome. I'm attached to that. We all know that stress is one of those facts of life. Stress is something that comes into play when we need to do things to protect ourselves, the fight or flight. It's the kind of thing that you can be very anxious about the first day of school, the first day of work, the first time you stand in front of an audience like this and have to do a talk. It's a little stressful, but you get through that. It doesn't happen all the time, and after you've done it a while, it gets to be a little more routine and it's not as anxiety producing. Then there is this stress that we label tolerable, which is those things that are unavoidable. A family member dies, you know, your favorite grandparent dies. It hurts, you're distressed, but somebody's there to help you, and the graphic of the family member there to kind of pull them up to the top so that they aren't down there by themselves is the image that I want you to keep in mind about what's tolerable stress. Natural disaster may fall into that category, but you've got someone there helping you through it. You're not alone. It doesn't mean you aren't affected by it, but someone's helping you to navigate through it. The final kind of stress, though, is the one where this ongoing, repeated stress or abuse or neglect is happening. And what happens to the growing child, the developing child, when we're born, our brains are not completely done. There are some who say the brain isn't completely cooked until you're like 25 or 26. I don't know. I haven't raised a child, so I don't know. There's some in the audience who may say that's even still not done. You know, and every time I say that, I get a different response from parents and grandparents, so it's okay. But early on in life, the brain is still cooking, literally cooking. The myelin is forming, it's completing all the synaptic connections, and anything that goes wrong in development at that point means that the brain gets off to a bad start. Think of it like when you're renovating your house and you got to get a whole new electrical wiring thing. I lived in a house once where the circuitry was so old, every time I plugged in a new device, I blew a fuse. Think of your brain as having just enough fuses to manage this. That next level of continuous stress blows the fuse and repeatedly blows the fuse, and you've got no fuses left to go back to. That's what's happening with toxic stress. We are overwhelming the circuitry in the brain. It begins to rewire. And so that child who was on this path to resilience, perhaps, now can be derailed and put on this path to dysfunction, risky behavior, unhealthy outcomes. And that's what's happening to the child with adverse childhood experiences. That's where the connection begins to get made to what ultimately happens in our health that compromises our overall health status. So it's positive stress, which most of us deal with on a daily basis, tolerable, which comes and goes, and then toxic, which if we don't do something and intervene upstream, or at least intervene at a critical juncture before the rewiring is done, then that child is now on a different path. The reason this is important in medicine is because, as you'll see in a slide, a couple of ones down, is because as doctors, we are trained in a certain way. That 100-year-old curriculum is based on a way of thinking about the body, its function, and what disease is and isn't. What ACEs does is gives us a new perspective on how to view disease and new options for how to treat the diseases like hypertension, like certain forms of cancer, like cardiovascular illness, like liver disease, like COPD. These are all things that we now know can be connected to adverse childhood experiences. And that's important because, as you'll see from our ACEs pyramid, this is the first thing most people see when they hear about ACEs. Anybody who gives you a talk on ACEs that doesn't show the pyramid is really not talking about ACEs. This is how you introduce it most of the time. I use the other graphics because every now and then I like to switch it up. But you'll see at the bottom there are these experiences that people have. What I was talking about is that social, emotional, and cognitive impairment with that rewiring. If as a baby, I don't get the cues from my caregiver. I look at you, you look back at me. I make a noise, you make a noise. It's called serve and return. That's how babies' brains begin to develop the right kinds of synapses. If I, as the caregiver, you look at me and I look away, or you make a noise and I say shut up, that's a whole different set of cues that I've been given. And one of the things we do with families who are at risk for some of these issues if we don't intervene is begin to help parents and caregivers learn you're not spoiling the child if you do that serve and return kind of stuff. It's actually rather healthy and very educational for the child's growth and development. But if that impairment happens, then we move to the next level. That's when you get into risky behaviors. Smoking, drinking, promiscuous sex. There was some show where the kids used to hang out of cars and stand on top and drive real fast and stuff. Risky behaviors, those kinds of things. Or deciding to rob somebody or hit someone in the head because it seems like fun at the time. That's when you get to that stuff. On top of that, then you get disease, disability, and all kinds of social problems. Everything from chronic illnesses and the disabilities that go with those to entry into the justice system, expulsion from school, getting kicked out of the house, being homeless, wandering around, not being able to hold a job, and that sort of thing. And ultimately, these are the people who die earlier than the rest of the population. And it all goes back to these things that we call adverse childhood experiences. So there was a national study that was done, and then Tennessee is really at the forefront in many ways, despite some of the other issues that we have here. We're at the forefront of dealing with adverse childhood experiences. The governor and first lady have taken it on as their as personal champions for this. The governor's allocated in several budgets now, real dollars to support the work of this. And so a study was conducted here of the prevalence of ACEs in Tennessee. And as you can see, About a little over a third of the population that was surveyed reported having no ACEs. We suspect this is gross underreporting because, as you remember from the first slide, the kinds of things that constitute ACEs are the very things that people are most reluctant to talk about. How many people walk in the door to a doctor's office and say, "Hi, when I was 7, I was sexually abused," or "My mother beat me with the extension cord every day of my life for the first 7 years," or any of those other things on that first slide. People tend not to talk about these things, which is why how we engage them, how we train the next generation of healthcare professionals to engage them is going to be critically important, because the sooner we get this information, the sooner we can do things to help with helping them feel better. And then the numbers show that at least 2/3 of them had 1 ACE, which means 10 is the magic number. The ACE questionnaire has 10 questions. You get 1 point for each yes. Anybody who scores over 4, we suggest needs to have someone do a more in-depth conversation assessment with. And then almost 1/3 had 3 or more ACEs. 1 in 4 had 3 or more ACEs. So of 10 questions, this is a lot of people with a lot of stuff that we didn't know was going on that has been seriously impacting their overall health and well-being. ACEs can have a lasting effect on your health in the form of all of those things. Most importantly, the kinds of things that we routinely as healthcare professionals don't do a good job of treating. How many people successfully treat obesity? Okay? Diabetes is on the rise. It is no coincidence that there is a connection between the development of diabetes and ACEs. Heart disease in certain populations, certain kinds of cancer, chronic obstructive pulmonary disease, accidents that result in broken bones. These things are on the rise and have some connection to ACEs, those behaviors, those risky behaviors, unhealthy behaviors that I was talking about, smoking, alcoholism, drug use, promiscuity, and those things, risky activities, engaging in risky activities. And then most importantly, in terms of future, the potential for a good quality of life. Graduation rates are impacted, academic achievement, lost time from work. All of these have a correlation to adverse childhood experiences. The National ACEs study, in fact, said that if you had more than 4 ACEs, these are the numbers. You're almost 4 times as likely to have chronic bronchitis or emphysema. That's something that is avoidable. Avoidable. We know that. 2.5 times as likely to have hepatitis or jaundice. Twice as likely to have heart disease. Almost twice as likely to have had cancer. Over twice as likely to have fair to poor self-rated health. So these are people who are aware that they are not well, but they haven't yet made the connection between what's going on in their past that is contributing to this. So if you look at it, in the center of this really should be a circle for the individual patient and family. But this particular graphic talks more about the way to change our systems of care to being more ACE aware, ACE informed, ACE sensitive, is to begin with this new philosophy. I don't know why this clicker is kind of on and off. New philosophy and approach at the core of this, because that's how the change starts. I heard some conversation earlier about if we're going to change the curriculum, we've got to have a real fundamental basis for what we expect on the other side. And that means we've got to have some agreement about what it is we want to accomplish and what that means in terms of value and philosophy. And is it that we want to your question earlier, young man, do we want to have people who graduate because they want to take care of people, or do we want to have people who graduate because they want to make money? I'm in the camp of, I came into medicine to take care of people, but making money ain't a bad thing. So, it doesn't have to be an either or proposition. And I think the trouble with even setting the baseline of a philosophy is we're swimming upstream, if you will. The culture of medicine is older than 100 years. And it is deeply ingrained in a way of doing things that has stood the test of time for most people who could afford to have healthcare. For people who were dependent on someone to get healthcare, the medical culture has not served them well. In fact, it has been a real problem for underserved populations since the beginning. And so creating this new philosophical base is the first challenge that we face. It's not impossible, but it is going to take some hardcore work and some persistence and some understanding, as Dr. Warren said earlier, some understanding of, if I came into it for this, I can't let anybody take this away from me. What I've got to do is figure out how I keep it while this culture that is around me that does not support my attitude and my belief system is being forced to change. And that comes in later when we talk about support for STEM programs and beyond. It's one thing to get kids into these programs, it's another to support them getting through them. And again, I'm from that generation that was trained when there was a lot of money to support minority retention programs. And so we had supporters and mentors and advisors and people who ran you down if you missed class and made sure that you stood your ground. So that's the first thing. That's the first thing we've got to do. And then, before we can even talk about providing the services, we've got to have better policies and funding for those policies, because that's what drives the programs and services. I spend a fair amount of my time today, since I work in juvenile justice, on this, figuring out what policy change needs to be made to drive the funding in the way that I need it to go, to have the programs that I need so that professionally we can do the services that we want. It's a real hard job, and I don't encourage anybody fresh in the business to tackle it, because you really got to have some thick skin and a high energy level, and a little bit of seasoning, because you need to know how politics works. And for the, what is it, post-millennial, who have the social justice but not the patience to do things within a certain structure, they've got their way of doing it. I like that, by the way. You really do need to have people like me, like Paul, like Ruben, to really kind of help you work through this. It's good work, and I encourage everyone who aspires to be a healthcare professional to figure out how to be an advocate, because that's what this is all about. This is not lobbying, this is advocacy. And people out there who need these services need us, the experts, to be advocates for them. But then you move from the policy to the programs and the services, and then you get to the professional practice and the standards of practice and those sorts of things. And what's in those arrows going around the perimeter are all of the systems, the multiple systems that either interact or impact to get done all of the work in these central circles. And it's a wonderful experience to watch systems change. To actually see things happen. There are a couple of national model programs. One is called the System of Care, actually, that are fundamentally reframing children's mental health and bringing families to the table, bringing children and the families to the planning table, to the implementation table, to the evaluation table in ways that they were never there before. That's a good model because it's evidence-based. It's been around for 30 plus years. It's required to submit an evaluation every couple of years that actually gets read, because in order to appropriate the next level of funding, people want to see your outcomes from prior years. So it really is a very good model for what we need to do in this work that we're here talking about today. So that's sort of the workflow, if you will, of where we need to go in changing the curriculum to address how we incorporate adverse childhood experiences into medical and other healthcare professional training. There's a woman, this Dr. Nancy Hart, and she actually has a video on YouTube, so you can look her up. I decided not to show the video for this presentation, but this is part of a series that she did in this newsletter, ACEs Too High News, and it's at acestoohigh.com, so you can look it up. She wrote an article to accompany several of her videos, and this one was titled, "The Most Important Thing I Didn't Learn About in Medical School Was Adverse Childhood Experiences." And this is just a quote from that article In fact, it's how she starts the article, where she talks about everything that I now know about ACEs. If I'd only known in medical school, I would have been such a better doctor. I would have been more compassionate, and I think we were talking about compassion and empathy earlier. I wouldn't have felt like such a failure when my patient who was overweight didn't lose weight, when my patient who was diabetic got crazy blood sugars all the time and swore that they were doing everything I told them. I wouldn't have gotten so angry at the smokers, drinkers, drug addicts, and others, because I would have understood that it wasn't what was wrong with them, it was what had happened to them. And that fundamental shift in our thinking, whether you use motivational interviewing or just the regular history and physical taking that we train medical students, or if you're in psychiatry, the mental status exam and all that goes with that initial history, just that change from what's wrong with you that you're not getting better, I'm giving you the best treatment, to what happened to you that you're at this place with all of these things going on. Just the change, teaching a medical student to change their tone from being accusatory to being caring, empathic, compassionate, understanding that I'm not doing this, just to be difficult about. I really don't know what's going on. Shows them that you care, and it also opens up for the physician, I think, the possibility that I might actually be able to do some good. And that's, I think, one of the things that we are failing today to impart to our young medical students, to our residents, to the folks who are out of training and now on their own practicing. They don't know how to share that. If you say too much, you've lost that barrier that we're supposed to keep up between the doctor and the patient to keep everything kosher. But if you don't say enough, patients get the feeling that you don't really care anyway. I'm just a number on your checklist today, and as soon as you see me, you're going to check off you saw me. I tell this story because it's true. I fired a doctor once because it was during that early transition to everything on the computer, and I couldn't get her to make eye contact with me. She was so busy doing this, and I finally said, look, you're nice, I like you, and I really wanted to see you because I've heard good things about you, but if you can't adjust to what I need, I'm gonna have to go elsewhere. So she said, well, I've got to get this stuff in the computer, and I said, well, then I got to go elsewhere, because I'm old school. I need to watch your facial expression when I tell you this and see if I should be worried, about what you're about to tell me. And she understood it, but I'm sure she didn't change her practice. And that's sad, because she really was a good doctor. And I think people wanted her to show that empathic side as opposed to getting things done. So I would encourage you to take a look at Nancy Hart. She is one of those doctors who I think gets it and is trying to make a difference in the lives of the people that she's working with and training. I think I will leave you with this, and it was shared with me by a graduate of Meharry. Oh, he's gone. A graduate of Meharry Medical College, who every chance he gets talks about the wonderful training that he had here to be the kind of doctor that he always wanted to be. And he has maintained that. Community doc, working south side of Chicago now, seeing people that no one else will see, working in places where no one else will work, doing the good work that Meharry taught him. But he shared this with me. Risk factors are not predictive factors due to protective factors. And if ever there was a mantra for why ACEs are so important, the kids who are impacted by ACEs the most are the ones that we call the at-risk kids. We all know them. This is an at-risk population. We're studying an at-risk population. Our clinic serves an at-risk population. Those kids are at risk because of things that are out of their control. As adults, they're at risk because of things that happened to them when they were kids, when things happened that were out of their control. That should not predict their outcomes. And if we pay attention to what ACEs, the science, because this is not just Dr. Stewart says, I think I woke up this morning and think this is what's going on. There's an actual science underpinning ACEs. You can look it up. You can read the studies. You can check out the articles. There are books. The Body Keeps Score. The Body Keeps Score. Anyone read that? You've read it. The Body Keeps Score, wonderful volume for understanding the science behind this. Can't do it justice in 30 minutes, but I would encourage you to do that. I would encourage you to look at the work of Nadine Burke-Harris, a pediatrician. She has the best TED Talk on, as far as I'm concerned, next to Brian Stevenson. She is the second best TED Talk I've ever heard. And Nadine has completely transformed her pediatrics practice in California to be ACEs informed, and she is, as far as I'm concerned, the poster child doctor. Because she's younger than me, I can call her that, for ACEs and incorporating ACEs into medical care. So risk factors that we see in ACEs that we should be taking better care of in medicine and healthcare should not predict one's outcome in life, health or otherwise, because there are protective factors, and that is us. The healthcare system can be a better protective factor for these folks. Communities can be better protective factors for the kids who are at risk, and for the families of those children. Someone said earlier about, sticking, coming in one way and continuing to be that way when you leave. I think the missing ingredient is that we don't have the right protective factors in the training arena. I can believe in social justice, but if I'm about to be evaluated by someone who says that doesn't matter, and if you say it again, I'm failing you, I'm gonna stop believing in social justice publicly. And you will see a different me on the floor. I will have, I remember during my surgical rotation, being with this really, and I hope there are no surgeons in the room because I don't mean to offend, but this man was truly crazy. And he put me out of the OR one time because he said I touched the back of someone, which is absolutely a no-no. Now, I was too far away from the action to have touched anybody, but I wasn't able to keep quiet about stuff outside of the OR, and that was the place where he could put me in my place. So putting me out of the OR, as much said, you don't belong here. And I was kind of actually happy to be out. But it was because all he wanted to talk about when he wasn't operating was sailing. And I knew nothing about sailing. I didn't know what the boat was called. He's talking about these different boats and doing this and that. I didn't know anything about that. I was in Philadelphia trying to become a doctor, to work with people. I didn't intend to have a sailboat. It was never on my bucket list to have a sailboat, okay? And that didn't play well in his world because we had nothing in common. The stuff that was important to me, he didn't even know about. He didn't care about. And since I wouldn't accommodate him, he needed to extrude me like a cancer. And so I got put out of the OR. I did pass the surgical rotation, but I knew for sure then I would never become a surgeon. Because if you had to do that kind of change, y'all can see I can't keep my mouth shut. I wasn't going to fit well in that environment of we live high on the hog kind of stuff. That wasn't for me. So we can all be part of that protective factor, though, for those young people who really do want to become doctors and nurses and social workers and psychologists and techs of some kind. We can do that, but we've got to be intentional. I heard that word earlier today. We've got to be intentional about it. And as we are looking at this curriculum change, we've got to factor in two additional things. They look up to the people that teach them. And I'm dealing now with a situation with faculty who don't believe it is their problem to understand the challenges. I'm here to teach, and it's their responsibility to figure out how to get it. Well, that's not really true. Because if you're not teaching what they need, then I really don't think I need you. But I'm not the dean or the chancellor or anybody or the chair, so I can't get rid of people. But I can encourage my department, at least, to begin looking at ways for faculty to get, and we'll dress it up, professional development, in-service training. Give it a nice euphemistic name, give them some CMEs, and then hold them to a standard. Put that into the faculty evaluation. It's going to be a process, though. The other thing is, above the level of faculty, the buy-in at the very top has got to be solid, committed, unrelenting. that sometimes is a bigger sell. Depending on your timing though, and the situation, like this week has been a boondoggle for me of why we must pay attention to certain things. You know, the whole incident around the unfortunate situation a couple of days ago opened people's eyes to things that I've been saying that now they want to have conversations on. And I just happen to have a whole list of things to help them with it. You know, so sometimes it is all about time. But that's part of the protective factor. I heard your point about people in admissions committees and evaluations and everything. We have got to figure out, as part of this curriculum change, how we build that in at the foundation of this. Because without that, we're gonna consign these kids to be hanging out there alone like me in the OR. And then that's how you reach me if you wanna have more conversation. Thank you.